welcome to Be Empowered, our podcast, where we dive into the realities of healthcare and entrepreneurship. This is an unfiltered, unapologetic, and always a dose of empowerment. We're here to amplify voices, both yours and ours, to challenge the status quo and to explore what it really means to thrive. So let's get into it. Today, we're going to be talking about the state of the US healthcare system, what's broken, and what needs to change. It's a pretty heavy topic. I think we can talk about this topic for multiple episodes, but today we'll start with addressing a few of the things that we find to be the most challenging. So let's start off by talking about kind of where me and Shala are living right now. I live in Brooklyn, New York. Shala, where do you live?
I live in Walnut Creek, California.
Okay, so two of the most highest cost of living areas in America. So, Shala, why do you live in Walnut Creek, California?
So, my husband was born in San Francisco and he grew up in Reno, Nevada. It's interesting that I'm kind of from overseas, but we met in Blacksburg, Virginia. It's a crazy story. But I applied for fellowship and I got into Stanford Fellowship and I moved to the Bay Area for that. But of course, after my training was over at Stanford, I couldn't even live in Palo Alto or Silicon Valley, interestingly enough, as a physician, two physician families. We were kind of looking at our numbers with the loans that we have to pay off. We decided that, okay, let's look at a little bit more affordable area compared to Palo Alto. But we wanted to stay in the vicinity because we love the area, we love the schools. So we decided to settle on Walnut Creek, California, which is about 30 minutes east of San Francisco. And it's still within the vicinity of Silicon Valley, but not in, I would say, in Silicon Valley where the prices are almost double or triple.
Outrageous. Yeah.
Outrageous, exactly. But having said that, we are in Walnut Creek. It's still a high cost area. Our house that we purchased, we were lucky to be able to purchase. We were competing with a lot of other people who are in tech and putting in cash offers, So it was a bloodbath, and we were able to do this during COVID, a little bit after COVID, I would say, but it was a bloodbath. We had to put many offers. We had to compete with a lot of different people to be able to get our house. Even though we are two physicians, but really wasn't easy. It's still not easy. Our mortgage is not easy to pay. It's not, it's not easy. Yeah.
Absolutely. I grew up in the Silicon Valley, so I know very much so, but I grew up in Silicon Valley before it is the current Silicon Valley. We moved here right in the 1990s when things were starting to take off. So I do understand how expensive it was then and how ridiculous it's become now. I have chosen to live in Brooklyn, New York for a few reasons myself. So I did grow up in California and then I lived in the South a little bit for training. And my parents have since moved to North Carolina for retirement. So now we're in the same coast, which is, I think, helpful. But I moved to New York for training. I did my fellowship at a big academic center here. And once I came here, I just really enjoyed being in the city. I liked everything that the city has to offer, the conveniences. I met my husband in the city. He's from Virginia. But I think between him and I, we really valued being in New York City. And even though we don't live in Manhattan, we live in Brooklyn, which some would argue is just as expensive, if not more expensive than Manhattan. Our neighborhood is really nice. It's not quite as urban. It's a little bit more suburban. If anyone knows the boroughs of Brooklyn, they do know it is family friendly. But even with that, me being a physician and him being in sales, there's no way in heck we can afford a home here. The average home, despite this not being in Manhattan, is $2-3 million, which is the case in Silicon Valley as well. But the reason we like it here is, like most high cost of living areas, one, it's near good health care, right? I mean, you can
Mhm.
certainly live in rural areas, but what are you going to do if you get sick? You're going to have to travel 1 to 2 hours, which to us, it's just not okay. Two, diversity. We like that the people around us look like us. And we like that there's a lot of culture here. And we like that we can go out and get different cuisines, that there's museums. And I'm sure those are all the things that you also like in the Bay Area.
Right.
So I think, part of the reason we started off with that is because the argument has always been for healthcare workers, why go to low or why live in very high cost of living areas? Why not live rurally, live like a resident, and pay off all your loans? And for a lot of us, that's just not very appealing for all of the
Right.
reasons Shala and I just said. Life sometimes takes you in different places, and those places might not necessarily be rural, and you shouldn't have to live where you don't want to live, right? Especially if you put in, I was going to say 10 years, but I think it's longer than that, like 12 years, even more in terms of honing your craft.
Yeah, exactly. I agree. For me, it was 13 years after basically my kind of high school, including research,
Hmm.
as I did 1 year of research. So after all that, all those years, and of course, we are at we're not in our 20s anymore. We are in late
No.
30s or even 40s. And then to say that the norm should be that you live in a low cost area and pay off your loans and live like a resident and don't travel too much, don't do
Hmm.
this or don't do that, and don't spend just to pay off your loans and think about the future. It's not really practical, or not really
No,
realistic or appealing, as you said. I can't even imagine if after doing that, you get some setback in life, or some people
exactly. If
have
you're sick,
that.
your
Exactly.
family member gets sick, something happens to your kids, God forbid, then what do you
Exactly.
do?
It comes down to that because a lot of us who started a little bit late or had some, time that we took off, our life is later. And then we get to this
Hmm.
age where our parents are aging as well. And so you have to be around to take care of your parents or your in-laws. So we don't have the luxury to wait longer, to wait more even, to be able to enjoy our life, which may be very short amount of time. So I think that we really need to rediscuss or reevaluate this norm of live like a resident after you graduate and pay off your loans and live in a low cost area where it
Hmm.
might not be desirable for you or your kids.
This really brings in the first thing that I think is helpful or important to discuss when it comes to the challenges of the current healthcare system. It's the rising costs and financial barriers for people to even enter healthcare, right? Like what Shala and I just discussed, our journeys, where we are now in life, why we are where we are in life. All of that took a lot of training. It was 4 years of medical school, 4 years of training, 2 years of fellowship, not even counting high school researchers, any gap years. Imagine the delayed gratification there. And, certainly some people might listen to this who are not in medicine and roll their eyeballs, right? Like, oh, you guys are doctors. You make so much money by the time you're done. But the reality is, if you're not coming from money, then that financial barrier of entry to healthcare can be very intimidating because if you don't have anyone to help you, guess what? From what 21 to 30, you're making less than minimum wage. You have delayed gratification, as in you don't have any retirement, you don't have savings because you're getting paid like what in the South, I was getting paid $50,000 a year. And not to say that you can't live off of that. I definitely lived off of that, but you can't live off of that, have savings, have a family, um, have any assets. And more importantly, you can't pay back the loans. I think most of us, I graduated with about $350,000, and that's not even including interest. And I know, Shala, yours is probably similar as well. And you're a two physician household, so you're going to have double that amount. So that
Exactly.
financial barrier, I think, needs to be addressed if we want to motivate like more people to enter medicine. And that needs to be discussed, because who in their right mind wants to do all of this if it's going to be so difficult for them to start making money, start paying back the government, and living like a normal human. I mean, most of us saw our friends in college doing so much better than us before we even got to where we are now.
Right. Yeah, I agree. Yeah, my husband and I have upwards of $800,000 in loans. And he was lucky because his parents were able to afford paying for college for him for the 4 years of college degree.
Hmm.
But I did not have that financial support during college. So I did get some scholarships and some grants, but it wasn't enough. It wasn't enough to be able to live without working. And it was not able I was not even able to work, during university time while
Hmm.
studying, because you want to do really well in your school during that undergrad time so you can get to medical school. So you really have to be full-time student. It's not feasible
Right.
to be able to do night jobs. I was spending most of
Exactly.
my time, exactly, I was most of the time I was sitting in the library with my
Hmm.
friends and just studying all the time, in addition to preparation for the MCATs. So that was another kind of, in addition to my regular studies, I had to study kind of the New York Times, the Wall Street journals, all what's going on in the news and in healthcare. So I'd be able to uh, interview well for medical school. So
Right.
I'd be able to have that knowledge on the verbal reasoning part of the
You
MCAT.
you did more than I did, that's for sure.
Yeah.
Sorry, keep going.
Yeah, and it was just it was so again, it's all, it's not just during the training, it begins even before the training, before the training. So it was rough, it was rough. And then to say that you go through that and then you're still told, live like a resident, continue that living, because
Yeah.
you want to pay off a loans. And the loans are another issue. So when I graduated, my loans were, there still are, the interest rate is close to 7%. And these are
Hmm.
government loans. And the private loans out there, the interest rate on the private loans are, 4%. It depends on the time. Now the interest rates are higher. So
Hmm.
why is it that, these student loans that are government loans are having, interest that high? It's just not, and then they're not even tax deductible, so
No.
the interest rate is that tax deductible, but having that much loans, it doesn't even put you at a better financial uh, tax bracket,
Hmm.
so that is very kind of strange to me, that how physicians and healthcare workers with higher amount of loans are at a significant disadvantage, even in terms of their loans and their loan repayments.
It's basically robbery. My dad says it's like
Yeah.
highway robbery that the government can charge this type of money. And I think some of the rhetoric I've currently heard people say is, well, if you can't afford to take those loans out, don't take those loans out. Well, guess what? A lot of us made this decision when we were, what, 19, 20, 21, with zero financial literacy, right? But then my second point is, if that is the rhetoric, like don't take out the loans if you can't pay them back, then you'll never have teachers. Never have anyone going into healthcare. Everyone will take these loans out and try to go to Deloitte. That's not a functional
Right.
society. You know what I mean? If you are trying to pursue something that is for the betterment of society, I think, especially with all the work that we've put in, we should, at the very minimum in residency, be getting paid enough to start paying these loans back. And I think if we can facilitate that, and some of the residencies are unionizing, which I'm very happy for them. There's no reason why residents need to get paid like garbage, honestly. If we can increase what we're getting paid in residency, I think we can remove some of these financial barriers that are causing such a challenge for people to even think about entering the healthcare system, or be completely frazzled once they have entered, because then now they're like, I see the residents saying this all the time. I finished med school with a $380,000 loan. Like, what the heck do I do with this?
Right. And even
Yeah.
during residency, I think it goes back to this work-life balance. Unfortunately, we do see a lot of residents who switch their specialties or even
Mm-hmm.
drop out, because there is no, I mean, you have people telling you, you can't spend too much money because you're going to have a lot more loans to pay off. And then
Mm-hmm.
on the other hand, you're spending all that time, just in the hospital in a high stress environment. You don't have family, most likely. You don't have kids, most
Mm-hmm.
likely. So, and then you can't travel to see other countries or have a
Enjoy
hobby,
life.
enjoy life because you don't want to spend that much. So then
Exactly.
so basically, all of that starts, from medical school, residency, and then it just continues to later time in life. When I grew up, no one talks about the challenges of becoming a doctor, even before someone becomes a doctor. We know all the sacrifices that doctors make. We know all the sacrifices that the healthcare workers make, but we don't talk about the details and the details um,
Mm-hmm.
of becoming a doctor in this country are very challenging and difficult to address.
Exactly. And because no one talks about it, I think the general public doesn't perceive that, right? They think we are making so much money. We're sitting in our penthouse apartments overlooking Central Park, just taking all their insurance money. That's what the general public thinks of us.
Right.
And whereas there are some doctors who are doing extremely well, the vast majority of doctors, I mean, heck, pediatricians, primary care providers, I would argue those are some of the most important doctors, are
Right.
making like $180,000, which, it is a good amount of money, but imagine you start making that in your mid 30s after you've left with compounded interest on your student loan, and now you're sitting on 500,000, let's just say. It's not equivalent to the amount of time you spent putting in the work. And I think that is a big disservice that no one talks about it, because I think if the general public saw that, they would realize that we're just the face of a broken system. We don't we're not taking their money, essentially. It's trickling up to the CEOs, the administrators, a whole bunch of people who have no business being in healthcare. And physician reimbursement, there's charts and stuff out there have readily been dropping. Doctor salaries, I believe, only make up about 3% of all of the healthcare expenditure, whereas the number of administrators keep growing, and they're making more salaries. You can be an administrator and be making more money than a physician, which I think is ridiculous.
Yeah.
Um, yeah, and that takes me to point number two, which is burnout. And you already started talking about this, Shala. It's a good segue to it. But all the news outlets talk about burnout in healthcare workers, especially after COVID. I believe one of the latest studies said that about 45% of healthcare workers are frequently burnt out. I would say it's even more than that. I think people don't talk about it because it's stigmatized. It's something that we're taught is embarrassing. You're not supposed to talk about how tired you are. It's part of this toxic culture. Um, and a lot of the burnout is because there's work overload, especially in residency. If you look at any list, the AMA's list, whatever, they always talk about how physicians, especially female physicians, are 2 to 3 times more likely to experience burnout than the average public. And doctors also have a very high rate of suicides, which is, I think, very, very sad to think about, especially because these are smart, driven individuals who put so much into this career.
It's a very important topic. And the other thing that I was going to add is the tuitions have increased. I mean,
Hmm.
back in the days, you would think, and that's why I think the general public think or perceive physicians to have a very luxurious life, going to luxury places for vacation and things like that. But I think it's because they don't have the updates because life was like that for physicians, 20, 30 years ago, where two physicians are able to afford mansions and live
Oh yeah.
very happily and, not be overburdened by
Even
documentation.
one, they'd have like stay-at-home wives. Imagine.
Exactly. Imagine, yeah, stay-at-home wives, multiple kids, they can afford it. There's no way that we can do that. I mean, my husband and I, there's no way that we can survive on
Hmm.
one person's salary. It's just both of us have to work to be able to afford living in this area and to be able to pay off, some of the loans that we owe. So it's very changed. And that's why I think the general public needs to know that that's just not the same. And back in the days, yeah, physicians used to see a lot of patients every day, but they were not overburdened by notes of defensive medicine where we have to write stories of novels in our documentations to protect ourselves even medical legally. So that's another challenge that will be another episode for medical legal
Right.
challenges that the physicians have.
Yeah. So malpractice is one thing. The other thing is, I think, in terms of patient satisfaction, right? That's something everyone focuses on. And I think definitely you should aim to satisfy your patients. Your patients should feel good under your care. As a patient myself, I would like that. But I think when reimbursements have gone down and they're so low that your clinics are packed that you have to see 20 to 30 people a day. I know primary care providers are churning through patients. When you're doing that, you can't give patients the amount of time that they might need, and they might not be satisfied. So now you are overworked, your scores or whatever metrics that your hospital or your employer is looking at is low, um, and you're getting underpaid as well. So all of those things together definitely lead to burnout. Before you even get to that point, in residency, you're burnt out. So now you were burnt out for 4 years, and now you're burnt out again. And again, you can't enjoy life because everyone's telling you got to live like a resident. So what do you do with that? Do you just stay miserable? Is there a solution? And I think that's why so many healthcare workers are depressed. There's the substance abuse is high. Unless you're able to create boundaries or set some kind of plan for yourself where you're exiting this cycle, um, it's challenging. I personally, like I said in our first episode, I considered leaving the field myself because being overworked and underpaid just was affecting my mental health quite a bit.
Definitely. And a lot of us, I'm sure you may have, and I know other friends have experienced this feeling of being stuck even in residency, right? Of
Hmm.
okay, I started this and I already have loans. I can't quit, so I remember I even got sometimes I wished, I mean, this is horrible now that I think about it, but there was a time that I would wish that I get into, an accident or something, or I break my leg so I don't have to go to the hospital for a few days and get some time off. It's to that level of stress. It's unfortunate. And then, so you feel stuck. Okay. And I thought to myself that when you're done residency, when we're done fellowship, and now you're making good money, right? Or supposedly making good money, now you don't feel stuck anymore. But in the initial stages of life after residency, after training, actually, I did feel stuck, and a lot of my colleagues felt stuck as well. I have a colleague who, after fellowship, went to an academic job. She felt stuck too, even after her training. She was like, okay, at this point, I started this, and the lack of education and the lack of information about other jobs, of what's out there and what are our options, is just you take the first option on the table,
Hmm.
and then after you take that, you feel lucky to have a job. And then especially when you compare your salary to the residency time, you're like, okay, this is great. I can
Oh,
live.
I'm rich.
Yeah, I'm rich. I'm rich. I can live. I can live very comfortably off of this salary. But then, if you think deep down about it, is that that's when you start having your kids, that's when you start buying your house, your expenses significantly increase, because that's how life should be. You should have your house, you should have your car, you should have the car that you want or the house that you want. You should be able to send your kids to good schools, that to get the best education. You should be able to go to a restaurant, you should be able to travel to Europe and Hawaii and other places. You're a physician, for God's sake, right? So then you're like, if I wanted to be able to do this, then I have to work 5 days a week, even more than that, and then be on top of everything, right? And give even more than the 40 hours, give more, be more committed. So in the first couple of years after residency or after training, and fellowship, there is still that feeling of being stuck.
Right. Yeah, because what other job at this point is going to pay you enough to pay back your loan? And
Right.
some people have made the transition to pharma, but that's not easy to do. You and I both know that. We have friends in pharma. That's not easy to do. So
Right.
now you're an attending, your schedule is maybe a little better, but you're still really, really burnt out. And so what are you going to do? You can't quit. This is the only thing you've known for 12, 14, 15, even longer, you know? It's not like you're going to learn a new skill and
Yeah.
join tech. That's just not going to, trust me, if I could do that. But so you are stuck, and I think when that happens, that's when physicians leave. That's when healthcare workers leave. I've seen so many posts on social media with physicians, nurses, everyone quitting. It's because they're burnt out, and that brings me to my third point. When the financial barriers are high and burnout is so high as well, we're going to have a shortage of healthcare providers. No one's going to want to go into healthcare or medicine, because why? Why would they? As our population is aging, the boomer population is getting into their retirement age even more. Who's going to take care of them? I don't even know who's going to take care of us. The
Right.
way things are going right now. So there's a shortage of healthcare providers, and I think the solution to that the companies have figured out is to hire APPs, PAs, and nurse practitioners. But those guys are also being underpaid, right? And
Yep.
I think one thing that the corporations have done that I think is very smart is they've put MDs against APPs when we all have the same enemy, I think. Um, and that's the administrators, honestly, because now what they're doing is there's all these schools. I think PAs, it might be a little better for it this time, but and there's so many online programs where you could just go, never have any nursing experience, and you come out and you can practice independently in so many states. And so I think that's what people are trying to do to try to replace physicians. And why not? They're getting NP, like NP level care, which is, I guess, technically MD level care is what they're assuming it is. And a lot of the public likes NPs as well. But they're also burning out these nurse practitioners. The nurse practitioners don't realize that they're making so much money for these companies and they're willing to take less pay. So the way the companies look at it is, hey, I get the same thing as I do with an MD, but for half the cost. Why the hell not? So I think that's kind of where we are right now in 2025, unfortunately. Given the rising cost of going into medicine, the high burnout rate, a lot of people are either dropping out of medicine fully or just not entering in. And now we're seeing a shortage of healthcare providers, which means the mid-level, I don't know if the appropriate term is mid-level, I think it's APP at this point. Now we see a lot more of those APP providers practicing medicine independently, which I don't know. I don't know if that's good or bad, and I think that's kind of the current day challenge that we're faced with.
Yeah, so I think the same phenomena is happening with APPs as well. We see a lot of the APPs, the new grads are
Hmm.
experiencing the same thing as us. Basically, they go into hospitals, they go into clinics where they have to see, I've heard even some APPs have to see 70 patients a day in a 12-hour
Mm-hmm.
shifts. I mean, that's just crazy to me. So new graduates, I think,
Yeah.
taken advantage of. And so once they realize what's going on, a lot of APPs start exploring other options as well. I mean, I see a lot of APPs that are going into cosmetic medicine,
Mm-hmm.
into
Aesthetics.
aesthetics, right? Into IV therapy, into other options that are less stressful and high paying, right? They are also experiencing the same way, but without the same loan burden and with less years of training, basically.
Exactly. And so, definitely we addressed a few of the challenges in healthcare, and I think we can certainly keep talking about this. But ultimately, administrative burden, staff shortages, excuse me, resource limitations, moral distress. And I think the moral distress applies throughout. It's not just MDs, it's all healthcare for workers where we feel like we're morally injured. What we think is correct is not aligning with what we've been told by our bosses is correct. And I think you see that a lot with the nurses unionizing and striking for better ratios. You see the residents doing the same thing. So I think all of those things are playing into a role in compromising patient quality, which really is the important thing here. I think all of us in healthcare, the workers, the frontline workers anyway, care about patient care quality, but our employers may or may not be feeling the same way. And I think if if they don't get on the same page as us, I can see this getting worse. And I think these types of conversations are important because we need to have these conversations amongst ourselves and with the general public to make real change and meaningful reforms. Like we need to advocate for ourselves, for our patients. We need to support each other, which I don't think we do often. Anytime I'm on with healthcare workers, everyone's yelling at each other, everyone's saying one thing, another person saying something else. I think we need to come together to support each other because these are just a few challenges we laid out in this conversation, and it's not even the tip of the iceberg.
Right. You brought up good points. One, supporting each other. Supporting each other is very
Hmm.
important. And that's why I feel that nurses are doing a better job in doing that. They have the union, probably that's why. But as physicians, we need to do a better job in that. And I think it comes to kind of educating the public,
Hmm.
educating the admins, educating the patients, and ultimately, unfortunately, the patients are the ones who pay for this. I mean, the patients, and
Exactly.
we also as
And we
patients,
are
as
also
future patients,
patients.
exactly.
Yeah, our family members are patients. Our parents are, getting up there. So this does worry me.
Right. Even, some of us may be current patients, some of us might be future patients. I mean, I can even tell stories about my personal
Hmm.
challenges when I go to a doctor, and I'm a doctor myself,
Right.
or the bill that I receive after, doing a test when I'm already paying into premiums, so it's not just for everyone else. Me as a doctor is experiencing this as well. And ultimately, we all have to pay for it. I hear stories of physicians declining to take or accept specific type of insurances like Medi-Cal or Medicare, and that affects the patients. Ultimately, we will get to a point where only those who can afford to pay can get
Hmm.
the services, but those who cannot afford to pay, unfortunately, will not be able to get the services, which is terrible. This is not why we came to medicine. This is not why we became a doctor. But I feel that a lot of doctors are put in that situation because they ultimately have to think about their self advocacy and their own life and their own time, and value themselves and value their time. So it's becoming more and more challenging.
Yeah, absolutely. I mean, we see a lot of the primary care doctors going away from insurance and doing direct primary care. And I understand why they're doing it. And sometimes patients do prefer that, but if you're already paying so much for your insurance, why should you have to pay more to get a PCP? You know what I'm saying? I think the way the system is set up, it should ensure equity in terms of who is able to afford medical care. You shouldn't only be able to see a good PCP if you can afford to pay out of pocket. And I think, definitely this is a conversation we should continue into other episodes because there's so much to talk about. But I think, the bottom line is I think we need to advocate for each other. We need to support each other because not only are we healthcare workers, we're also the patients. And I think with the general public seeing what we're talking about and hearing what we're talking about, I think together we might be able to make more of a change, if we can get community engagement and hopefully help create a stronger, more sustainable healthcare system. But who knows? I mean, the way it is going right now, I am concerned. I feel like who's going to take care of our parents? Who's going to take care of us? You and I know, have had conversations about, like, are we still going to be continuing this 10 years down the line? When I was growing up, doctors were doctors still, they were 80, 90, they never stopped working. But the way things are going right now, there's only so much someone can take.
Yeah, I definitely, even my mindset have changed. I remember a few years ago when I first uh, graduated, I was thinking, oh, I'm going to do this until my 60s and 70s. Why not? I love it.
Hmm.
And I still love it. But I'm getting to a point where, like, okay, no, work-life balance is important, is very important. The burnout is a big issue, and I am burning out. Um, so what are the ways that I can still continue to do this for many more years, until my 60s and
Hmm.
70s, but without having to deal with the challenges of it, being able to do it just out of love, not just out of necessity. And that's the
Necessity.
key. That's the key. Yeah, we don't, if your job is a necessity, then you have to do something about it, then there has to be a change because necessity is not sustainable.
Exactly. And this is not the type of job that you do just to pay the bills. It's too mentally challenging to be
Yeah.
a physician just to pay the bills. I mean, there are doctors who do that. I don't think they're great doctors, but if you're doing this out of love and passion, I think it's really hard to keep going in with that love and passion when you keep hitting a wall every single day because of the way things are set up. And I think, you know, we'll see. We'll see. We'll have more conversations about this, but I hope our podcast can make some kind of an impact or at least start a conversation.
I hope so too. And this was just, as you said, the tip of the iceberg. There is a lot to talk about.
Hmm.
And in the next podcast and episodes, we will dive into each of these challenges in more details and more stories.
Absolutely. Thank you, everyone, for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, share with someone who needs to hear it. Feel free to follow us on all of our socials. Oh my God, I can't speak today. It's at Empowermedlife, all lowercase, all one word on Instagram. You can email us stories that you have. We want to hear from you. Our email address is www.empowermedlife, all again, all one word, all lowercase.com. um we'll see you again next time, but stay strong, stay empowered, and stay tuned. Thank you.
Thank you, everyone.